Okay, well, welcome everyone to Pediatric Teaching today. Last week we talked about pain management and analgesia in children, and this week I thought we'd talk about procedural sedation. The two topics are quite related, aren't they? That often for some procedures we need to give some analgesia, so it's important to have an understanding of the analgesics we can give, but also there are some other requirements for sedation and some other requirements for procedural sedation. So I think this is a very common thing in pediatrics. We often need to sedate patients for relatively minor procedures, not major surgical procedures, but having a CT scan so that they lie still, or having a chest drain put in, or doing a lumbar puncture, and it can make the procedure safe and effective. And if the child is agitated or squirming or uncomfortable, then the procedure won't work properly, and you won't get either the specimen you need, or the images you need, or the drain won't go in as you need it. And so you need to, as part of pediatric training, you need to learn about safe procedural sedation, what sort of sedation and analgesia is required for different types of procedures. So that's what we're going to talk about today. This is an overview of procedural sedation, and with the aim that ultimately all pediatric trainees will be able to practice it and then be accredited as in procedural sedation. Just move on. So you can broadly divide procedural sedation up into sort of two main areas, I suppose. One is where you need very light sedation for a procedure that's not at all painful. So having a CT scan is not painful, but the child needs to stay still for the scan. So they need some sedation, but they don't need heavy sedation. They don't need analgesia for it. Then there are other procedures that are painful, and the child will need both sedation and some analgesia. So, for example, a chest drain insertion, sometimes in emergency departments, we do closed reduction of fractures, where not an open reduction, it needs to be done in theatre, but a closed reduction, and that is a painful procedure and needs some sedation for it. Suturing of lacerations, if you've got a large laceration that needs to be sutured up, then it's good to have some sedation for that, so the child stays still, so they don't get agitated and squirm around, so your sutures go well, if you like. Abscess drainage and incision, that's something that's commonly done, and it's useful to have some level of sedation for that. Doing bone marrow aspirates, it always works better if you've got a child who's just calm and quiet and sedated. Burn debridements and burn dressing changes, if you've got a child looking after a child who's got moderate or severe burns, then they need to have regular burn dressings, with sedation that can be done very safely with a child calm and not feeling any pain. Foreign body removal, like sometimes in emergency departments, a child will come in with a foreign body somewhere, and they need a bit of sedation. And even a lumbar puncture can, I think, often work better if you've got a calm, sedated child. And it depends on how sick the child is to whether we give sedation for a lumbar puncture or not. But for some children, doing a lumbar puncture, especially, for example, if they're an oncology patient needing to have intrathecal chemotherapy, then having them a bit calm and sedated is a very good thing. Okay. There are lots of different symptoms though, and it depends what you're trying to achieve. If you're trying to achieve analgesia because the child's got pain, then you use different medications. If another symptom is anxiety, so many children will have procedural anxiety, and then they need anxiolysis. They don't need analgesia. So it depends what symptom you're trying to relieve as to the type of medications or type of intervention you do. If the child's very agitated, they need sedation. If they need to stay still, if they're moving a lot, then you need less movement, so you've got stable operating conditions, so the child lies still for the CT scan or whatever. And if you're trying to prevent the child recalling what happened during the procedure, then you need to give something, a medication that also has amnesia as a property. So analgesia, anxiolysis, sedation, stability, less movement, and amnesia are all different sorts of things. And depending on the procedure, we may need to use a different combination of medications, or some medications have a number of these properties. It's just important to know what medications work for pain, what work for sedation, what work for anxiolysis, etc. There are many non-pharmacological therapies we can do for procedures, and I talked about this last week in terms of analgesia, but oral sucrose in a syringe, just a few drops on the tongue, and the baby sucks on the syringe while you're doing a procedure, and you wrap the baby up and cuddle them, is usually all that a newborn baby will need for a significant procedure. So if you need to, even putting in IV cannulation in a baby, give them a bit of sucrose on the tongue, and they will be they'll be more comfortable. You know yourselves, if you want to calm a baby down, you put them at the breast and ask the mother to breastfeed. Well, for doing a procedure, a bit of oral sucrose can help. It's only a few drops, and they're usually calm for a few minutes. There's other things you need to do if you're doing a procedure. I mentioned this a bit last week, but for most children from around about 2 or 3 years of age, they can understand what the procedure is if you explain it to them. So explain the procedures that you're going to do, and don't say that this won't hurt, because if it will hurt, then when it hurts, they'll think you're lying to them. So say this will hurt a little, but it won't last long, or this will hurt a little and then it'll be better. And I tend to speak frequently to the child if I'm doing a procedure. Just speak to them, calm them down. You sometimes, I think if children have to undergo a number of procedures, then using rewards after procedures, like give them a sip of fluid, or read them a story, or let them watch TV, or something that they know is coming after the procedure, so that they can be a bit calmer about it. And most children, if they've had a procedure and they're able to feed afterwards, then they'll be much calmer afterwards if you give them a feed afterwards. I talked about this last week too, and there's some good research now done on what videos are helpful in calming children and enabling safe procedures. And one of them, one's called Naloya. You probably all know about Peppa Pig, and then Rafadan Taifa is an Arabic video. They're all very good, and they're for different ages. So younger children, children of preschool age, and then school age children. There's a video that is entertaining for all different ages, and I often use videos just on my phone or on an iPad to show children that are having procedures, and that can reduce the amount of sedation and analgesia you need to give. It can distract them really well. So I would recommend incorporation of non-pharmacological treatments in many procedures, not all, but some. Now, you need to decide in regard to the procedure you're doing, is the procedure painful or not? I already said this before, but CT scans versus insertion of a chest drain or an abscess drainage, obviously the last two, they're painful procedures. A CT scan's not painful. Do you need to reduce movement for the procedure, or is it all right if the child moves a little bit? For a CT scan, often the child has to be very, very still. But for some other procedures, a child can move around a little bit as long as they're not trying to jump off the bed. The main thing is decide how much movement you need to reduce, and then decide whether you want to give the sedation orally or intravenously, or even intramuscularly, depending on the procedure. And then decide, is the child low or moderate risk? And this is fairly straightforward. There's many different ways to assess risk, but the way I do it is through history and examination, and you can divide children up into low and moderate risk. When you do a risk assessment, you need to all these things are important. So the age of the child's important. The younger the age, like neonates and young infants, they're a higher risk of, say, apnea during a procedure, whereas older children are at lower risk. What other medications are on, what allergies they might have, if they've had a previous adverse reaction to sedation or a general anesthetic, if they've got a past history. So if they're an ex-preterm baby, or they've had seizures, or they might have epilepsy, or if they've got heart or lung problems, then that's important in terms of determining risk. When you do an examination, you're looking for these things too. So check their airway to make sure there's no stridor and the airway is not obstructed. If a child's got any evidence of airway obstruction, then when you give an anaesthetic, it's going to be worse. So it's important to know, assess your ability to open the jaw, bring the jaw forward so that you can support the airway if they needed to. Mostly, when you give the sort of sedation I'm going to be talking about, the child's just asleep. They're not anaesthetized. They're not so deeply asleep that they lose their airway at all. So that shouldn't happen. Assess the need for oxygen. You always have oxygen with you when you're doing procedural sedation, just in case. But if the child's got pre-existing lung disease, for example, some chronic lung disease or got asthma, then they may be at more risk of a breathing problem when you give them some sedation. And assess their cardiovascular risk. Make sure they don't have any signs of circulatory impairment, and assess their A, B, C, D for disability or neurodevelopment. Obviously, children that are hypotonic, that is floppy, or have spasticity, are at high risk of complications during even light sedation. Low risk means they've got no pre-existing illness like most children, and that their airway, breathing, circulation are all normal. Whereas high risk, to me, if they've got any emergency signs, or they've got a pre-existing illness affecting their airway, breathing, or circulation. And I think that the two, if you divide children up into those two risk groups, then that you can understand which ones are very safe to do and which ones require a bit more care and maybe some more expertise. For most procedural sedation, you need two operators. One, I think, is a doctor at a registrar level or a specialist who's had some training in procedural sedation, and then you need that person's assistant. So someone who's someone accredited in procedural sedation plus an assistant, and that assistant could be another doctor, it could be a resident, or it could be a nurse trained in procedural sedation or in critical care, someone who can manage the airway and the breathing safely if the child got into trouble. Some procedures, like just doing a CT scan, one operator is enough. If it's a non-painful procedure requiring light sedation, like chloral hydrate or something only, one person is enough. But a second person should always be available to be called and attend immediately any child deteriorates. And so it is important to have more than one person there, even if the procedure itself only requires one person. For most painful procedures, I place an IV cannula. Sometimes, if you're giving intramuscular ketamine, you don't need to, but usually placing an IV cannula makes sense. Sometimes you need an IV because the child will need some IV fluids during the procedure, or if they got bradycardic or hypotensive, they might need some medications. So it's useful to have an intravenous cannula for most painful procedures. For a CT scan, you can usually just use chloral hydrate or some midazolam, and the child will be asleep for the period of the scan, and you don't usually need an IV. So for low risk sedation, for medical imaging or other non-painful procedures, then in general there's no need for an IV. You should always have oxygen there, but I only give oxygen if the child needs it. And one reason for that is that it's good not to give oxygen, but watch the child breathe, because you should be watching to make sure the child's not having bradypnea, like slow breathing, or apnea, periods of cessation of breathing. And any child who's not doing that, if they're breathing steadily, then they should remain well oxygenated. It's only if they get a problem like airway obstruction or their breathing slows, then you need to find out why that is. What problem is going on? Not just give them oxygen. If you just give them oxygen and they're breathing very slowly, then that won't work. So I don't give oxygen unless there's actually a problem, and then I try to find out what the problem is, and then fix that. Visual monitoring of their chest is more important. You can watch their chest rise and fall. You can watch their lips. That's what you should do. One person, if there's two people, one person doing the procedure, the other person doing the sedation, then you should designate that monitoring person to watch the child's face and mouth and the motion of the chest, the movement of the chest. You can do continuous pulse oximetry if you have it. So continuous pulse oximetry just to watch the saturations, measure the vital signs at baseline, and measure them after administration of the sedative drug and on completion of the procedure and at the completion of the recovery. So you need to measure their vital signs about 4 times during the procedure. So before you start, after the sedation drug, the completion of the procedure, and then there's a time for recovery, and then do the observations then. Often after the medication's been given, then complications are more common. They're less common, sometimes even 5 or 10 minutes after the medications have been given. Airway obstruction or hypoventilation or hypotension will occur. And sometimes immediately you've finished a procedure, then a child will become hypotensive. And that's because they've maintained their vascular tone during the procedure. And then because any discomfort is gone, they lose their vascular tone because of the medications you gave them. It depends what medications you're giving, but just beware of when you finish the procedure, it's not over. You still have to watch the child for for monitoring post-procedure, at least for 15 minutes or half an hour, depending on the drug that you've given. So I just wanted to go through a few of the drugs we commonly give for procedural sedation and just say how they're a bit different. So chloral hydrate is obviously an oral agent, and it's used for sedation only. It doesn't have any analgesic properties. And so if all you need to do is have a child sedated, then chloral hydrate's a good drug. If what you want, though, is because you're doing an uncomfortable procedure, you want the child to have analgesia, then chloral hydrate alone won't do it. Similarly with diazepam and midazolam, they're for sedation only. They also have an amnesic effect, but they're sedation only. There's no analgesia provided by those sedative drugs. Ketamine, however, is both analgesic and sedative, and it has an amnesic effect. And so if you do a procedure with ketamine, then depending on the dose, you'll get good analgesia, you'll provide good sedation for the child for the duration of the procedure, and they won't remember it afterwards. Morphine and other opioids are strong analgesics, but they provide very minimal sedation. So you should never rely on opioids or morphine to try to sedate a patient. It just won't work. It's very good analgesia, but it's not very good sedation. If you want local anesthetic, then lignocaine is very good. And I think for many procedures, you can use a combination of an analgesic, some sedation, local anesthetic, and then you've got all things covered. So chloral hydrate, as I said, is not analgesic, but it is a sedative drug. It's only really for diagnostic imaging for children under 3 years of age. It's not so good for procedures. You get an onset 15 to 30 minutes after an oral dose of about 25 milligrams per kilogram. Sometimes people give much more than that. They may give 40 or even 50 milligrams per kilogram. I tend not to do that. I think then you start running into problems with hypotension, apnea. So I think 25 per kilo is about the right dose. Chloral lasts for somewhere between 1 and 2 hours. So after the procedure, after the CT scan or whatever you're doing, then you still need to observe the child for the next hour or two afterwards. Midazolam, as I said, is not analgesic. It's a benzodiazepine. If you're going to use it for painful procedures as a sedative, then you also need to give an analgesic, whether it's paracetamol or whether it's an opioid or ketamine. it has a very rapid onset after intravenous injection. So you get an effect almost immediately, and it lasts for around about 45 minutes to an hour. After oral midazolam, the onset takes 15 to 30 minutes. So IV works immediately. After oral, it takes 15 to 30 minutes. You can give it intranasally, and that works a bit quicker because it's absorbed a bit better. And then you get about an hour of sedation. I wanted to spend a bit of time talking about ketamine because I think it's a very good drug for most procedural, painful procedures that I've talked about. Like I always use it for putting in chest drains. I use it for other incision and drainage of abscesses. For some lumbar punctures, I think it's a good sedative and analgesic. The doses are about 0.5 to 1 milligram per kilogram. If you've got a child who's sort of moderate to high risk, then I always use just little aliquots of 0.5 milligrams per kilogram intravenously, and then you usually get 10 to 15 minutes of procedure time. And it's quite easy to titrate because when the child starts moving again, you just give them some more. You can give them 1 milligram per kilogram at the start, and that might last a bit longer. But I always like to see just what effect the smaller dose has on their breathing and on their airway and that sort of thing. And then if the 0.5 milligram per kilogram works well, then I give the other half easily, no problem. If you're giving it IM, then it's given you need to give a double dose, 2 milligrams per kilogram. The onset is about 5 minutes after you give the IM injection, whereas with IV, you get the onset almost straight away. With IM, you get a bit longer procedure time. So you get about half an hour procedure time, but it is more difficult to titrate. You can't just keep giving small aliquots because if you're giving it intramuscularly. So I tend not to use much intramuscular ketamine. I prefer to give it intravenously and just give aliquots along the way. If you're doing a procedure that lasts for half an hour, a chest drain insertion or something like that, then usually you need to give a second dose, especially when you do stitching in the chest drain, for example. Ketamine, it's important to understand what ketamine does because it's what's called a dissociative anesthesia. It produces dissociative anesthesia. So sometimes the child will have their eyes open even after they're sedated, but they won't be aware. They won't be aware of what's going on. You can often see, to start with, you see some nystagmus. The child will have some nystagmus, and that indicates that the child's well sedated. So the sedation itself can last longer than the analgesic effects. So the child, given the sedation, can last for up to an hour. You need about an hour of monitoring after ketamine. For some children, they'll get some adverse effects from ketamine. There's a condition called emergence phenomenon, which when some school children and adolescents are coming out of their ketamine sedation, they start to see some hallucinations, and that can be a little bit distressing. You can overcome that by giving a bit of midazolam as well at the same time. But having said that, most children do very well with ketamine for most procedures, young children and older children. But I'm always a little bit wary of the adolescents when I'm giving ketamine and try to give a bit of midazolam as well. Ketamine is good because it preserves upper airway tone. You don't lose that airway, so a child will maintain their airway even after a dose of IV ketamine. And the child just keeps breathing away comfortably, usually without any respiratory depression. Sometimes it's very rare. I haven't seen this very often, but sometimes children get vomiting when they recover. So you need to make sure if they're sedated, they're not lying flat on their back looking at the ceiling because they might vomit and aspirate. So that's important. I always use a local anesthetic as well if I'm doing a painful procedure like an abscess drainage or a bone marrow aspirate or a chest drain insertion. Always put some lignocaine in the local area. That can be just as good, just as important as the sedation you're using. And I use a 1% lignocaine solution usually. I've gone through really the basics of procedural sedation. Not talked about any particular procedures, but more about the sorts of medications we use and the non-pharmacological therapies you might use. But I think it's important they're all properly accredited in procedural sedation. This is an important thing for paediatricians to know. So I sent around a sedation guideline that I think it's really the notes from this lecture, if you like. And I think it'd be important that you could read them and understand them. And you may or may not want to watch this lecture later on, and then have some practical demonstrations with one of your senior colleagues. The sorts of things you should practice for procedural sedation are things like jaw lift to keep the airway open, airway suctioning, just make sure you know how to safely suction an airway, giving oxygen by bag and mask or by face mask. So just being able to give oxygen, knowing when a child's, knowing how to monitor a child properly, and then bag mask ventilation. I think to be properly accredited, you should have done at least 5, maybe up to 10 procedural sedation procedures with ketamine or chloral hydrate, and demonstrated competency under direct supervision by a senior pediatrician or an anaesthetist. But I think it's possible that all of us, all the trainees, can learn about procedural sedation and be good at that for these procedures. So I haven't talked about something like how to put in a chest drain or how to do a procedural central line. We might talk about those things at another time, but I just wanted you to have a good understanding today of procedural sedation.